Hello, I'm David R. Jones of the Community Service Society. For most poor and working poor New Yorkers, the cost and the quality of health care has always been a critical issue. Health care is our topic today on the Urban Agenda, and the new president of the New York City Health and Hospitals Corporation will join us. Joining me now is Dr. Benjamin Chu, the president of the Health and Hospitals Corporation. Prior to his appointment by Mayor Bloomberg, Dr. Chu was a dean at both the Columbia University College of Physicians and Surgeons and the NYU School of Medicine, and had previously served as senior vice president at HHC. Welcome, Ben.
Thank you very much, David.
It's no secret in the prior administration under Mayor Giuliani, serious questions were raised as to why New York City has a public hospital system anyway. Maybe you could describe why you think it's necessary and what the magnitude is of this system.
Well, David, as you know, the public hospital system in New York is the largest public system in the country. We have 11 acute care hospitals, 4 nursing homes. We do 1 million ER visits and over 4 million outpatient visits. And we take care of a significant number of New Yorkers. In fact, in any given year, 1.3 million New York City residents come through our doors. But I think the most compelling reasons for why there needs to be a public hospital system is that over 500,000 of those 1.3 million New Yorkers are uninsured, meaning they don't have a usual source of payment for their care. And that's always been our burden and our mission. We take care of every New York City resident, regardless of ability to pay. And I think in the prior administration, even though there was this big move to privatize the hospitals, that it was a clear community consensus that the core mission of the corporation could not be achieved without the public hospital system.
Well, what happens if I don't have insurance and I end up at another hospital, a voluntary hospital? There are no really for-profit hospitals in New York at this point.
They're all
so
voluntary.
What happens if I have a problem, if I come up to another hospital?
Well, I never want to disparage the voluntary hospitals, because the voluntary hospitals do provide a lot of uncompensated care. Right. But there is no compelling reason for them to have to. Nothing compels them to have to take care of you, except for in the emergency room situation. The obligation stops with stabilizing you and finding an alternative source for you to go to.
And
care.
Of course, this isn't only morality. The question is that when someone comes in with no insurance, the costs can be staggering in terms of uncompensated care for a voluntary hospital.
That's right. That's exactly right. And when you really think about it, about a quarter of New York City residents are uninsured, give or take a couple of percentage points here and there. But actually, by last count, it was 1.7 million people in New York City are uninsured. And that can be a staggering burden for any system, voluntary or public.
And other cities in America, what do they do? What does Los Angeles do, Chicago?
Well, Los Angeles has a large public, as a matter of fact, the second largest public hospital system in the country. And of course, they face very many of the same problems that we do, particularly with the undocumented. California has a very acute problem with numbers of undocumented residents of Los Angeles that use the public system predominantly.
So in terms of this system, 11 acute care, what does that mean? What kind of hospital system do we have here under your leadership?
Well, we have a system that provides the entire continuum, from outpatient medicine to emergency room, and if you get sick enough to require an in-hospital stay, we have 11 acute care hospitals that take care of everything from helping you give birth to your child, taking care of your child who might have asthma or something like that, to sophisticated heart surgeries and neurosurgeries. So we really provide the full gamut of services.
Now, I should reveal to the audience, I'm not totally a disinterested observer to HHC. I served on the HHC board, actually, when you were a staff.
And you were a wonderful friend.
But I also was privileged to serve on the selection panel that recommended your name through to Mayor Bloomberg, so which was a great satisfaction. Sometimes life comes full circle, and it is an honor to be with you today. But let's go into the realities. Obviously, there's a tough budgetary situation confronting the city of New York. We have a $5 billion budget deficit this year. I've heard rumors that it grows from there in the next fiscal year. How is the Health and Hospitals Corporation faring in this kind of budgetary environment?
Well, our budget is roughly $4.3 billion, so it's a huge system with a lot of resource needs and a lot of resource expenditures. But the fortunate part for us is that most of our revenues are derived from third-party payers. You know, we actually only get $120 million, actually it's $124 million in direct city subsidies for care. I mean, the city does contribute. They help us with our debt service. They do provide us a large chunk of money for the uninsured, but through the Medicaid system. So there are other sources of money from the city. But when you actually look at the direct subsidies that we rely on, it's relatively small. And our share of the budget cuts comes to around $40 million. It isn't quite settled yet. I know there's been ongoing negotiations.
Right.
And when you think about it, $40 million, while it hurts, in a $4.3 billion operation, particularly with the, what I'll mention in a moment, with some revenue opportunities on the other side, I actually think that we actually have at least the wherewithal to be okay.
Before we go into the how you're going to meet the budget shortfalls, there are centers of excellence at the Health and Hospitals Corporation. As a board member, it used to be very frustrating because some electeds tried to portray the system as a total disaster.
Right.
In fact, what do you see as the real, extraordinary centers of excellence at the existing HHC?
Well, I think you have to look at each hospital separately. I've had the very distinct pleasure in the last 4.5 months to go to all of our facilities, not once, but many, many times. I've been to some of the facilities 5 or 6 times, and that's when you actually have as many facilities as we do. That's a lot of traveling, but I love going to the facilities because each and every one of them are unique, and they really serve as an anchor for the communities that they serve. But there are many specialty areas which are really jewels. I mean, probably the best kept secrets, so to speak. For example, injury prevention program at Harlem Hospital is really absolutely nationally renowned. In fact, the Rob Wood Johnson Foundation recently gave the injury prevention program at Harlem a national grant to take this nationwide.
And what's the idea behind that?
Well, the idea is that, in the 80s when we were seeing tremendous amount of injuries to children in particular, primarily from the environment and primarily from a whole host of environmental factors, the pediatric surgeons whose lifeblood is to operate on children decided that this was just not good enough. So they went out to the community and looked at each and every step of the factors that contributed to childhood injuries and attacked them. They pushed for window guards. So New York City has,
Which
one
used
of
to kill hundreds.
Amazing to have babies fall out of the first or second stories. It's just unforgivable.
In the 50s, it was the stories in most of the papers when I was growing up.
And all you need is the window guard, and really they cut down playgrounds, designing very safe playgrounds as opposed to those where, remember when we were kids, those swings that used to go right at head level.
Head level and hit you for sure. Well, also, of course, the emergency care at places like Bellevue and Kings County.
Absolutely. We run the best. We run 6 out of the 12 trauma centers in the city. The Poison Control Center is at Bellevue, really one of the best poison control centers in the country.
And microsurgery, I think you had at
Bellevue. We do microsurgery. If you have your limb cut off and you need it attached. It's the only place to go. It's the only place to go. Actually, I think Montefiore does it as well, but really the place to go is Bellevue. But it's not just emergency care. You run down HIV care. We have some amazing mental health programs that people don't really know about. but that are actually very proactive, trying to interface with the community to really work with our patients and our clients to integrate them better.
Now, in terms of the budgetary problems, you have a $40 million hole.
Mm-hmm.
You clearly have extraordinary expense needs as well.
Right.
The system has things that need done. How are you approaching that in terms of trying to get this on a fiscally stable and prudent path?
Well, the first and most important strategy, David, is in New York State now, in this day and age, there are a couple of public programs which you have to give credit to the Assembly and the Senate and the Governor for having put through. Not only do we have Medicaid, we have Child Health Plus, probably the best Child Health Plus program in the country. And now coming online this year is Family Health Plus.
Now, these are insurance programs? What are these?
They're public insurance programs
Right.
designed to cover people without insurance.
And these are low-income people?
Low income, right. There's income threshold. We started with Medicaid
Right.
and then added children to make sure that just about all children actually qualify for either Medicaid or the new Child Health Plus program. Right. And now Family Health Plus covers the parents of children and certain single adults up to an income threshold.
Now, does this include immigrants?
It does include legal immigrants.
Okay.
The undocumented still do not qualify.
And what is your estimate of the number of undocumented people who come to HHC at this point?
Well, the number of undocumented, that's hard to get at.
Right.
But I would say that there are estimates that New York State probably perhaps 500,000 undocumented. I don't think we see 500,000 HHC,
No.
but we see a significant number.
And basically, they don't just come for routine care. These are people who are really in
They
need
usually don't come until they absolutely need it.
Right.
And
So you need acute
know,
services.
That's right. If you don't have a source of payment for care, or you're afraid that you're going to get caught and shipped back to the country of origin, you don't come until you really need it.
Risk it.
Right. That's right.
We'll be right back to continue the urban agenda.
In America, you are not required to offer food to the hungry or shelter to the homeless. There is no ordinance forcing you to visit the lonely. In fact, nowhere in the Constitution does it say you have to provide anything for anybody. Thank you for all you've given. Imagine what more could do.
Welcome back to the Urban Agenda. We're talking about health care with a new president of the New York City Health and Hospitals Corporation, Dr. Benjamin Chu. Ben, we've talked about some of the good things that are going on in HHC. Clearly, there are many challenges you're facing.
Sure.
Clearly, the public's perception of the public hospital system is not universally laudatory here. The long waits in the emergency rooms, the lack of skilled personnel, the lack of adequate supplies and nursing. Now we're facing an even further cut in all that. Where are your priorities here? Clearly, there are things you have to fix first. But what are you working on first to try to make this a better system?
Right. Well, I think that you're absolutely right, that there's a public perception of the system that's not necessarily that favorable. And I think the first, absolutely the most important thing that we can do is to really change the way our patients come through the system. You're absolutely right. I'll be the first to admit that, coming through the outpatient department, for example, could be an all-day affair, right? You could spend all day going through the system. And that is our number one priority. We're actually, in the first year, we're looking at how we take care of our patients in the outpatient setting. We're going to redesign the entire visit with the goal, actually, believe it or not, of trying to get people in and out of the door from the moment they step in for their appointment to when they leave, hopefully with the prescriptions in hand, of under an hour. Now, you were on the board, and it's sort of an unheard of expectation, but when I was at Harlem, we actually did that. Harlem and Lincoln, we piloted a couple of things to redesign the visit, put into place this open access redesign of the outpatient visit that we're doing, and we were able to achieve that. We took visits that lasted traditionally lasted 3 and 4 hours, and cut it down to under an hour, 52 minutes to be exact.
The other problem that we faced, obviously, is the morale of your staff.
Sure.
Clearly, the staff morale and your ability to pay competitive wages is something that's going to have to be dealt with.
Well, you know, I think that when you look at it, you know, sure, you can find discrepancies
Right.
here and there, but overall there has been an effort to address some of the wage disparities. You know, we're tied into the city's collective bargaining for
Right.
many titles, but when you compare us to the voluntaries at this point in time, even for doctors, as a matter of fact, we're inching up to much more competitive market rates.
Well, something many of our viewers may not understand, that HHC has its own doctors, but also relies heavily on teaching institutions.
That's right. Well, we have contracts with teaching institutions to provide the doctors, and more we're actually hiring people full-time, you know, to do really to develop programs.
Now, one of the
full-time.
complaints, obviously, were patients were being turned over to interns and residents who were sort of practicing on them.
That's right.
And how is that starting to flow out? I mean, in my day, even before that, there were always issues of, are people getting the best quality care
Sure.
that they can if they're getting students?
Well, for the last dozen years, the HHC facilities, the public hospitals, have been moving very aggressively towards attendings, you know, a full-time presence of attendings who are responsible for the care of the patients that come to us. We still have residents, surely. We're very large, we're large institutions that train a lot of new doctors coming through, but I actually think that now there's a better balance, in fact, really the right balance of having attendings totally responsible for the care, with residents and students supporting that care.
Now, there's been an enormous impact, actually, from the 9/11. The attack on New York led to a whole slew of changes in a number of areas, but one of them was the creation of something called disaster Medicaid.
Right.
And would you explain that? How
Right.
that
Well,
works?
you know, when the World Trade Center came down, the buildings collapsed onto the computer system that was responsible for enrolling people into the Medicaid system.
And the
Child Health
Medicaid
Plus.
basically goes for people below $13,000 in income, or even less?
Roughly, that's
Right.
about right. You know, and even less.
So these are really poor people.
Right. But the ability of the state to enroll people in the Medicaid and the Child Health Plus program really virtually disappeared. So the
Right.
governor created this disaster Medicaid program, which is a simplified two-page process, two-page form, where the client self-declares that they qualify, you know, and then what the state did was it gave them the Medicaid presumptively for 4 months.
Right.
And in that 4-month period, 342,000 people enrolled, which goes to show that
There's a
if the
pent-up
programs were easy to get onto without the excessive documentation that is currently required, people will sign up. 75,000 of those individuals came to HHC.
And what did that mean for you in
Well,
terms
it meant
of bottom
that
line?
we saw about 100,000 patient visits,
Right.
admitted just about 1,400 in inpatient admissions. So it wasn't that many. But there are some interesting statistics. We saw about 6,700 women for gynecological issues, and this is just one area. Believe it or not, 4% of those 6,700 people came in and got worked up and were found to have either cervical or uterine cancer.
Oh, brother.
It's exactly what the healthcare system is supposed to do. Go
That's
out and
preventive.
find people early enough so that you can make
You
an
can
impact.
save their lives.
Exactly right. So I think disaster Medicaid, from my point of view, was a wild success. Now the real question is, can we continue it?
And what is the posture of that? I mean, 4 months is up. We're essentially...
Well, they're now going through an interview process to make sure that to try to get people onto either Family Health Plus or Medicaid through the normal
But New
channels.
York City's and state's Medicaid system is rather an anomaly. Other states and localities have very simple processes for
Right.
people getting
That's
on
true.
Medicaid. Why not New York?
Well, that's the question. Why not New York? There's a lot of people out trying to push, just learning from disaster Medicaid that there are definitely lessons we can learn about enrollment, getting people on. If the presumption is we want people who are entitled to these services to get onto them.
Now, one of the big issues in the prior administration was privatizing.
Right.
And that was really forced back by advocates like myself, others.
Right.
But there were some ideas of how HHC might garner new revenue if it began to work at it.
Sure. I think that the notion of use of public-private partnerships can definitely work. For example, we were talking earlier about using some of our campus to do assisted living. That's
right.
affordable for the patients in our community. Assisted living meaning for elderly, as they get older, they don't necessarily want to have the choice of staying home in not being supported very well or a nursing home. There are gradations that we really should be providing, gradations in housing and services that take you all the way through. And we actually are looking to do that both at Kings County and Queens. And in fact, there's a plan that we're pulling together to try to use some of the Seaview campus in Staten Island. I think those are the kinds of things that are important. In addition to that, we created a foundation recently to try to go after some philanthropy, corporate philanthropy, private philanthropy, because as we're rebuilding Kings County, Coney Island, Jacoby, and Bellevue, and I hope to rebuild Harlem Hospital sometime during the next couple of years.
Right.
There are definitely needs that we could meet better if we had other sources of funding to help plow into that.
And do you see any of those capital projects being endangered? We just talked about the operating loss of $40 million.
Right. No,
what about the capital side?
They're absolutely firm. It's a $1.1 billion rebuilding program that's absolutely secure, through a whole variety of HHC bonds. By the way, in another month or so, we'll be issuing somewhere around $300 million in new bonds, $600 million when you add the refinancing. So we're relatively healthy in the capital programs at this point in time.
Now, one of the other problems that emerged in prior time was the ability of the public and people who had concerns to voice their concerns to HHC.
Right.
How are the community advisories, which actually were one of the going? Are they beginning to reemerge?
Oh, they're great. I actually love the community advisory boards, the Council of Community Advisory Boards. I mean, they take a lot of time to talk to the whole variety of communities, but I've spent a lot of time in the last 4.5 months going to legislative breakfasts with the community advisory boards, meeting with them, going to retreats that we've had, and they're the eyes and ears of
and they're hospital specific. They're not system-wide
specific. But we've brought
specific.
them together really to begin to talk to each other, because the problems are common across communities, and this is a great city because of the diversity, but it's also a great city because so many different people can come together on a common agenda, and that's what we're trying to do.
Now, you're, obviously at the beginning, or hopefully at the beginning of 8 years or more of trying to retool the system. What's your vision of where you'd like to see it go in the next 6 to 8 years?
Well, for sure, the patient-centered approach that we talked about, getting people through much more expeditiously and with a lot of respect, and part of the physical facilities rebuilding is also telegraphing that respect we have for our patients. But I actually think that what I'd like to do is begin to build specialty programs and other clinical programs that meet tremendous gaps that we still have. There's a lot that's been said about disparities in healthcare for minority communities. Well, I think it's time we start to think about creative ways to address that. Cardiovascular care. Recently we announced just a small program, $3 million, to put together a multi-hospital specialty cardiology group called a Community Cardiology Initiative, where what we want to do is go out and find people early on in their diseases, bring them in, do the case finding, do the preventive work before they actually migrate to their full-fledged heart attacks. I'd like to do that with mental health. I'd like to do a lot more cancer screening, colon cancer, prostate cancer in particular. We do a reasonably good job with cervical cancer, reasonably good job with breast cancer. We could do more. But prostate and colon cancer are big killers in New York City.
Particularly among minorities.
That's right. And we're not going out there and we're not really doing the case finding. And so that's where I want to go. I want the system to become much more activist with the community, really be playing an essential role in going out and looking at the health of the community and really trying to develop programs to interface.
Thank you. It was very kind of you to come on and join us. My thanks to Dr. Benjamin Chu for joining us today. City healthcare services are vital. Today, 1 out of every 6 New Yorkers uses the public hospital system. In these times of budget cutting, we must be vigilant in protecting core city services, and we must ensure that all New Yorkers have access to medical care. Adequate health care is absolutely essential for a healthy city. I'm David R. Jones of the Community Service Society. Thank you for watching the Urban Agenda.
To comment on the Urban Agenda or for more information on CSS, contact Community Service Society of New York, 105 East 22nd Street, New York, New York, 10010. Area code 212-254-8900.